Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Volz. I want to start with a question. How does a medical recommendation that harms people, not just fails them, but actively makes them sicker, survive for nearly 2 decades inside one of the most educated, evidence-focused professions in the world? How does that happen? Because it does happen. And when it happens, it doesn't just stay in journals or conference rooms. It reaches families in Medford. It shapes what happens in exam rooms in Ashland and Grants Pass. It changes what parents hear, what surgeons offer, and what patients assume is simply the way things are. This episode is the foundation for a 3-part series on what Dr. Marty Makary calls blind spots in medicine. Makary is a surgeon and public health researcher at Johns Hopkins, and his 2024 book, Blind Spots, explores how medicine can get stuck on ideas that are incomplete, outdated, or just plain wrong. Today, I want to do 3 things. First, explain the basic mechanism. Why do blind spots form at all? Second, walk through 2 examples that make this concrete. One is about appendicitis, the other is about peanut allergy, and third, bring it back to Southern Oregon. Because this is not a story about bad doctors somewhere else. It's a story about how intelligent systems, including our own, can become rigid. And when they become rigid, real people pay the price. So let's start with the mechanism. A psychologist named Leon Festinger developed the idea of cognitive dissonance in the 1950s. In simple language, cognitive dissonance is the discomfort we feel when 2 ideas collide. One idea says, I know how this works. The new idea says, actually, maybe you don't. And when those ideas clash, the brain often does not respond by calmly updating the old belief. More often, it defends the old belief and tries to explain away the new information. That means the first response to challenging evidence is often not curiosity. It's resistance. Not because the person is dumb, not because they're evil, because they're human. Festinger famously embedded himself inside a doomsday group that believed the world would end on a specific day. He wanted to see what happened when the prophecy failed. What he observed was not mass repentance. It was rationalization. People adjusted the story so they did not have to admit they were wrong. One member, a physician, said something that has stuck with researchers ever since. He basically admitted, I have so much invested in this now that I have to hold on. That sentence matters, because once identity gets attached to an idea, changing your mind can feel like losing part of yourself. And medicine is full of identity. Training, status, habit, protocols, professional pride, years of repetition. All of that is useful. It helps doctors make fast decisions under pressure. But it also means medicine can become very slow to revise itself, even when new evidence is strong. So let me show you what that looks like. For more than a century, the response to appendicitis was simple. You take the appendix out. Fast, no debate, no nuance, diagnose, call surgery, move. That reflex made sense historically because appendicitis can absolutely become dangerous, especially if the appendix ruptures. But over time, what started as a reasonable high-stakes response became something broader than that. It became dogma. Makary talks about major randomized trials showing that for many uncomplicated cases of appendicitis, meaning the appendix has not ruptured and there are no signs of obstruction or generalized infection, antibiotics alone can work in a substantial share of patients. Not all patients, not every case, but enough cases that it should clearly be part of the conversation. He describes a young man with early appendicitis who chose the antibiotic route because he wanted to make it to his sister's wedding the next day. He did. No surgery, no recovery from an operation, and he got to dance at the wedding. Now, does that mean surgery is obsolete? No. It means the correct question is not, what do we always do for appendicitis? The correct question is, what is the right option for this patient in this presentation with this level of risk? That is a different mindset. Makary then describes what happened when he brought this evidence to another surgeon. The surgeon kept raising the threshold for belief. One randomized trial was not enough. Then 2 were not enough. Then 3 were not enough. Finally, the answer became, I just think you're better with it out. That sentence is the whole story, not because the surgeon didn't care, because surgery had become part of his professional reflex, and the new evidence was colliding with years of training and experience. Here in Southern Oregon, many emergency surgical cases funnel through Asante Rogue Regional Medical Center in Medford. If you or someone you love ends up in that situation, this episode is not telling you to resist surgery or second-guess emergency care from the internet. It is telling you something more modest and more useful. In a region like ours, where specialty access is limited and many people feel like they have to say yes quickly because getting care at all can be hard, even knowing that there may be a real choice matters. A patient in Medford, Phoenix, Talent, Ashland, or Grants Pass should not assume that the first framing of the decision is the only framing available. And sometimes that matters for practical reasons people understand immediately. Missing a week of work, missing a family event, childcare, travel, cost, recovery time, fear of anesthesia. Those things are not side issues. They're part of the decision. If the case is uncomplicated, it is reasonable to ask, is this definitely a surgical case? Is there a non-operative option worth discussing? What features on the scan or exam make surgery the better choice here? If antibiotics are an option, what are the risks of recurrence or delayed surgery? That is not anti-doctor behavior. That is informed patient behavior. And that, to me, is one of the big themes of this series. Not distrust. Better questions. Now let's move to an even more uncomfortable example. Around the year 2000, major pediatric guidance in the United States recommended that young children avoid peanut exposure and that pregnant or breastfeeding mothers avoid peanuts too, especially in higher risk families. The intention was protective. The idea was to prevent allergy. But the evidence base behind that guidance was weak, and over time the results moved in the wrong direction. Peanut allergy rates rose dramatically. Researchers later showed that early peanut exposure in infancy, especially in higher risk children under appropriate guidance, could substantially reduce later peanut allergy. The landmark LEAP trial, published in the New England Journal of Medicine in 2015, found a very large reduction in peanut allergy among children assigned to early peanut consumption compared with avoidance. That was a major reversal. And it exposed something deeper than a single bad guideline. It exposed how hard it is for medicine to unwind a fear-based recommendation once it has spread through parents, schools, pediatric offices, and the culture itself. Because once the message becomes, avoid this dangerous thing, the correction never travels as far or as fast. Fear scales quickly. Nuance does not. That matters in every field, but it matters especially in healthcare, where people are scared, time is short, and nobody wants to make the wrong call with a child. I want to be careful here. The details of infant allergy prevention are not one size fits all. A child with severe eczema, existing food allergy, or other risk factors may need a more structured conversation with a pediatrician or allergist before introducing certain foods. So the lesson is not ignore your pediatrician and feed your baby whatever you want. The lesson is that recommendations should stay tethered to evidence, and when better evidence arrives, the profession should update quickly and communicate clearly. That did not happen well here. Now bring this home. Jackson County and surrounding areas already deal with access constraints. Primary care is tight. Specialist access can be slow. In some households, getting a 15-minute visit is hard enough. Getting a nuanced update on changing allergy guidance is even harder. So when medicine corrects itself slowly, regions with thinner access get hurt more. The old advice can linger in the community long after the evidence has moved on. And when access is thin, people lean even harder on simplified rules. Avoid this, do that, don't question it. That makes sense psychologically, but it is exactly how outdated guidance survives in the real world. That is one reason local health literacy matters so much. If we want better outcomes in Southern Oregon, we cannot rely on national institutions to eventually trickle down updated nuance. We need people here, clinicians, parents, schools, community leaders, to build a culture that asks whether current practice is still current. For parents, that can mean bringing specific questions to a pediatric visit instead of assuming the internet summary is enough. For clinicians, it can mean asking whether the patient handout being used in the office is actually up to date. For schools and childcare settings, it can mean reviewing whether policies reflect current evidence or old fear. The real point is not that medicine is broken beyond repair. At this point, I want to name the obvious risk. An episode like this can push people towards cynicism. You hear stories like these, and you can start thinking, maybe nobody knows anything. Maybe all guidelines are suspect. Maybe doctors are just guessing. I don't think that's true, and I don't think it's helpful. The point is not that medicine is fake. The point is that medicine is a human system, and human systems have failure modes. Sometimes those failure modes are obvious corruption, but more often they're ordinary inertia. Status, habit, protocol creep, institutional embarrassment, fear of admitting error, fear of confusing the public, fear of malpractice, fear of being the first person in the room to say, I think the old rule might be wrong. That's what makes blind spots dangerous. They don't require villains. They just require enough friction to keep the update from happening. And if I'm being blunt, that friction is everywhere in healthcare. A busy clinic schedule creates friction. A medical culture that prizes certainty creates friction. The fear of confusing patients creates friction. Electronic health record templates create friction. Insurance rules create friction. The embarrassment of having confidently told people the old thing for 10 years creates friction. So blind spots are not random. They are what happens when new evidence has to travel through institutions that are optimized for consistency, liability control, and throughput, not always for graceful self-correction. That does not mean those institutions are malicious. It means they need help. Sometimes that help comes from researchers, sometimes from clinicians on the inside, sometimes from informed patients who ask the one clarifying question nobody else asked. Most blind spots do not announce themselves dramatically. They usually sound ordinary. That's just the standard of care. We've always done it this way. Let's not overcomplicate it. There's not really another option. Sometimes that language is appropriate. Standardization can save lives. You do not want a trauma team reinventing process from scratch in a genuine emergency. But in lower acuity situations, or in recommendations that have become routine over time, those phrases can hide the fact that medicine has stopped actively thinking and started running on momentum. That is a useful distinction because the goal is not to question everything equally. The goal is to recognize when a recommendation is clearly evidence-based and individualized versus when it may be partly running on institutional autopilot. So, what do you actually do with this? I think there are 3 practical questions every patient or parent in Southern Oregon can ask when a recommendation seems automatic. 1. What is the evidence quality here? Is this based on a strong randomized trial, a systematic review, long-standing observational experience, or mostly expert consensus? Those are not the same thing. A good clinician may not quote the journal on the spot, but they should be able to tell you whether the recommendation is backed by strong evidence or whether it's more of a standard practice pattern. 2. What are the reasonable alternatives? Not fringe alternatives, reasonable ones. If surgery is being discussed, is there a watch and wait or medication first option in selected cases? If avoidance is being recommended, is there newer evidence on graded exposure or a different risk framework? If a protocol sounds automatic, ask whether the situation is standard or whether patient-specific factors change the picture. 3. What would make us change course? This is the question almost nobody asks, and it's often the most revealing. What finding on the scan would change the recommendation? What symptom would make this more urgent? What new study or specialist opinion would change how you think about this? A good decision process includes update triggers. If nobody can name those triggers, you may be looking at a reflex rather than a reasoned recommendation. I know some clinicians may hear an episode like this and worry that it encourages second guessing or fuels internet medicine. I get that concern, but I think the opposite is true when this is done well. Patients who understand uncertainty and evidence quality tend to ask better questions, not worse ones. They are more able to participate in shared decision-making. They are less likely to treat every recommendation as either unquestionable truth or total fraud. That middle zone, thoughtful trust, is where good care lives. And in a region like Southern Oregon, where clinician time is scarce and trust is fragile, rebuilding that middle zone matters. I also think this series points to something hopeful. Southern Oregon is small enough that culture can still shift here. We have large systems like Asante and Providence. We have primary care shortages and access problems. We also have an integrative medicine presence in Ashland, Medford, and across the Rogue Valley that is often more willing to talk about root causes, uncertainty, and whole person context. Those worlds do not need to be enemies. In fact, one of the smartest things this region could do is build better translation between them. Conventional care is often best at acute care, diagnostics, and high-stakes intervention. Integrative and longer-form care settings are often better at nuance, behavior change, prevention, and helping patients think in systems. The blind spot problem gets worse when patients are forced to choose tribes. It gets better when the culture rewards good questions, honest uncertainty, and evidence-based updating across settings. It also gets better when local institutions decide that patient education is part of care, not an optional extra. Imagine discharge instructions that include current evidence summaries in plain English. Imagine pediatric practices that proactively update parents when a major recommendation changes. Imagine community talks in Medford or Ashland where people can hear in normal language what is settled, what is changing, and where judgment still matters. That is the kind of healthcare culture I want us building here. One that is more transparent, less defensive, and better at course correction. That is part of the larger mission of Reimagine Healthcare, to make our region better at using medicine wisely. If you remember only one thing from this episode, let it be this. A confident recommendation is not always the same thing as a well-updated recommendation. Sometimes the most useful thing you can do is gently ask the question that reopens the conversation. Is this still the best evidence? And over time, if enough people ask it, it can change the culture of a whole region. In the next episode, we're going to look at another blind spot that affects families here very directly: antibiotics and the microbiome. We'll talk about what happens when a tool that saves lives is also overused, what that may mean for children's long-term health, and why this issue may be especially relevant in regions with strained access and high urgent care use. If this kind of analysis is useful to you, subscribe to the Reimagine Healthcare newsletter at reimagine-healthcare.org. That's where we pull these threads together in plain language, with more local context, more practical takeaways, and updates on the healthcare issues shaping life in Southern Oregon. And if you know a parent, clinician, educator, or local leader who would care about this conversation, send them this episode. That is how this project grows, and it's how we build a smarter healthcare culture here locally. This podcast is for educational purposes only and is not medical advice. I work hard to get the details right, but if you hear something that needs correction or you have a strong counterpoint, reach out. Thoughtful pushback is part of how better medicine happens. Thanks for listening.